This conference will now be recorded.
Okay, my name is Joseph Tritola, and we're going to be going through Medicare compliance, and I have titled this course The Basics. First, there's just a couple of disclaimers that we have to go through since this is going to be recorded and we're going to put this up on our website for others to see. I just want to make sure there's no confusion by others that might see this. And number one, the course is not intended to replace AHIP or any specific carrier training. You still are going to be required to do that for compliance reasons. Number two, this is meant as a guideline only. This is not, the absolute rules. This is the rules to the best of my understanding. The agent is ultimately responsible for knowing all the rules and regulations. The presenter, which is me, is not affiliated with CMS, Medicare, Medicaid, the United States government, any state or local government, Veterans Administration, SHIP, or PACE. And finally, this course is not endorsed by any of the above. So what I'm going to do first is I'm going to dive right in to the marketing don'ts. And my intention is not to make this a negative module or teaching or learning, but basically kind of hammer out the things that you can't do, and then we'll spend our time on the things that you can do. And a lot of the things that you can't do should come as no surprise. It should be considered, what I think in the industry is common sense. One of the things that the Medicare Advantage market, not so much Medicare supplements, Medicare Advantage Part C and Part D plans, they have adapted is that there is to be no unsolicited contact, no unsolicited phone calls. And if you ever want to know what the definition of unsolicited means by them, the best way to understand that is cold calling. What we're not allowed to do in the industry is we're not allowed to cold call someone for the purpose of selling a Part C HMO PPO or a Part D prescription drug plan. That's a big no-no. No unsolicited door knocking, and also that also means no leaving door hangers or brochures. In other words, you can't walk around a neighborhood and leave things on people's door about Part C plans and Part D plans. You're not allowed to do that. You can do that for a Medicare supplement, but you can't do that for a Part C or a Part D. No unsolicited email marketing. You're not allowed to buy a list and send out a blast email telling people that you are an agent and you have Part C and Part D plans. No approaching anyone in a public setting. At the mall, they have the food courts. You're not allowed to go up to people. This would be a good example. Or if you're waiting online at a Walgreens or a CVS and you overhear somebody knowing you can help them with their prescription medication costs, you're not allowed to do something like that. That's prohibited. In terms of marketing. No calling referrals from existing clients. So you just sold a Part C plan in HMO. You look at your clients and you say, hey, do you like my services? They say, I love your services. You say, well, would you like to refer me to other people? They say, yes. Here's the names of my aunts, uncles, cousins, and friends, as well as their phone numbers. You're not allowed to call them. They must call you. You can send them a letter in the mail, but they're not allowed. You're not allowed to call them. That falls back into the unsolicited phone call. Even though they were referred from an existing client, you contacting them is unsolicited. You're provoking them. They're not provoking you. Here's the other one, and we're going to tap into this a little bit because of the nature of everybody on this call. And it's going to be the cross-selling aspect of it. What you're not allowed to do is you're not allowed to cross-sell non-health related products during the same time you are marketing health related products, and vice versa. So in other words, if you went out to go see somebody for a life insurance appointment, they asked you to come visit them, you're sitting down, you're breathing and eating and talking life insurance, you cannot sell them a health related product. You can talk about it, and I'm going to get into how you would do that compliantly, but you cannot sell it. So in other words, a Medicare Advantage application cannot be signed and dated on the same day a life insurance application is signed and dated. It must be on a separate, distinguished, identifiably different appointment. The other one is No comparing Part C or Part D plans to plans that you do not represent. So, for example, you're sitting down with somebody and you're recommending insurance company XYZ, and they ask you about insurance company ABC, and you do not represent insurance company ABC. You've never done their contracting. You don't have a certification with them. You're not allowed to compare them as an option to the one that you represent. That's a big no-no in the industry. And again, this is all centered around Medicare Advantage. This is a Medicare Advantage driven compliance module. So Medicare Supplement is a different animal. No bait and switch, which means that you cannot pretend to call people to sell one thing when your real intent is to market Part C and Part D plans. We get that a lot in the life alert and the burglar alarm space, where marketing companies will open up the door with senior products such as that and DirecTV, and then at the end of that marketing thing, they'll ask a question like, "Oh, would you like some help with your prescription medication?" And if the person says yes, the marketing company will then turn around and sell that lead off to an agent or an agency. That's considered bait and switch marketing, and that's prohibited. No using superlatives to describe a plan. We cannot use words like the best or the greatest. That's one thing that's very prohibitive. I know it's hard because it's in our language when describing something. If we have a conviction or a belief that it is in the best interest of the client, we want to use those types of words. But when describing a Part C or a Part D plan, you can't use superlatives. Obvious one, no high pressure sales tactics. Because we're dealing with people that are considered senior citizens by most states or nearing senior citizen stage, that's one thing that collectively as a group of all the states, they do not want or do not care for any high pressure sales tactics. No misrepresentation of any kind. This one's obvious. If you're an insurance agent, you know you're not supposed to misrepresent the product that you sell. You can't use terms like you are certified by Medicare. You cannot say things like Medicare endorses the plan, endorses us, or endorses that. You can say that you have taken a certification that has been required by Medicare. You can say that, but you can't say that Medicare has certified you. Couple of other ones, no discussing of 2019 plans prior to October 1st, unless an active member asks you about the ANOC. And ANOC is the annual notice of change. So you can't say to somebody, you know what, the plans are going to be looking a little bit better for next year. Let's start talking about them now. It's only September the 6th. The answer is no, you can't. No acceptance of annual election period applications until October the 15th. So on October the 1st, you can begin dialogue. October the 15th, you can begin accepting applications. And then the other one is no usage of the word free anywhere. I know that's odd and strange because where in this world does zero cost not also mean free? Where in this world does that have a different definition? But unfortunately, the Medicare gurus of the world have collectively gotten together, and CMS has put down the hammer that we cannot use the word free anywhere. I know it's going to come up in your conversation when a client asks you, "Hey, how much is this medication going to cost me?" And we're just, human beings, we're prone, our initial response is, "Well, I just took a look, it's going to cost you nothing, it's going to be free." So we just got to be a little bit careful with that word. Certainly don't put it in print. So what can we do? Okay, what are the things that we're allowed to do? First and foremost, before you have any prior conversation with a Medicare person about a Part C or a Part D plan, before that conversation begins, one of the things that you have to do is you have to document what's called a scope of an appointment. Okay, I'm going to show you in a few slides what exactly one of those looks like. And an appointment used to be defined as in person, belly to belly, face to face, eye to eye, touching hands. That has since been redefined, where an appointment now is defined at any time a person, whether it be live in person or on the telephone, has a discussion about a Part C or a Part D plan. Anytime that discussion occurs, even if it's electronic, it is considered an appointment by CMS standards. Anytime the beneficiary brings up the topic of Medicare, I like to use the term provoke. Anytime the beneficiary provokes you to talk about Medicare, you may proceed with the conversation, assuming you have permission to call. In other words, it wasn't an unsolicited cold call. And as long as you document in writing, which is the scope of an appointment form, what products the person wishes to discuss with you. So here's an example. You're sitting down with your client. You just had this wonderful life insurance conversation, and the client says, "Oh, by the way, can you help me out with my Medicare Part D prescription drug plan?" Absolutely. Before we begin, you just have to give me permission in writing with the scope of an appointment form as to what products you want to discuss, and then we can have a verbal conversation about the products. Now, I do want to let you know, but since we did life insurance business, we will not be able to do Medicare business today. I'll have to come back for that if I can help you. Okay, so that would be the compliant way to do that. What about if you're the one that provokes them? Okay, what about if you're the one at the end of your life insurance conversation, or at the end of your Medicare supplement conversation, you're the one that wants to provoke them about prescription drug plan or Part C, HMO, PPO? What if you're the one that wants to bring it up? Or if you want to bring up the fact that you can help them in this area. So how do you do that compliantly? Well, first and foremost, you want to follow the rules. You want to make sure it's not a cold call or an unsolicited contact. You certainly don't want to use any high pressure sales tactics. So those are the obvious. You don't want to misrepresent. Say things like, "Well, we represent all the different insurance companies," when you absolutely don't. But the way that the carriers have responded to this question, and the way that the understanding is, and how pretty much collectively the industry will look at this, is you want to draw a line in the sand. Okay, you want to completely separate one conversation from the other. And because we're dealing with typically an older clientele, we want to be very sensitive to this group of people. And we don't want to put them in any type of position where they might forget something, they might be confused, it might be overwhelming. In other words, we want to be the ones to take the lead to make things a little bit easier on them. So the first thing you want to do is you have to document in writing their permission to have a conversation with you about what products that they want to discuss. Second thing you want to do is you want to host that appointment at least. I mean, the rule of thumb is 24 hours, but we feel collectively as a group that you want to host that appointment at least 48 hours after your non-health related engagement has concluded. So you had your life insurance sale, everything went very well. You recognize the person is over 65. You have valuable resources that may or may not help them. You're the one that provokes by bringing up the conversation about helping them with their Medicare decisions. They're receptive. First thing you do is you get a scope of an appointment form. Second thing you do is you schedule a follow-up appointment to have that conversation at least 48 hours later. And that's the compliant way to do it. It's better. It's better for you. It's better for them. It's better for the companies, because the last thing you want is you don't want somebody calling, let's say, Humana to cancel their Royal Neighbors of America payment because they're confused, because you had all these different insurance company names all on the same appointment. And so it gets very, very confusing. One of the other things you can do is you can distribute business cards, flyers, pamphlets during the normal course of business. It is suggested that you use generic in nature and do not mention any specific plan or benefit. Otherwise, it must be approved by the plan and CMS prior to distribution. Or if you wanted to do plan specific, let's just say there's a particular plan that's very strong in your county, very, very strong and very, very popular, so to say. You can go to that particular carrier's website and use their already approved branded marketing materials. Many of them allow you to put in your name and your phone number, and it's already CMS approved. It's already CMS compliant. You can print it off and put it into places such as dry cleaners and pizzerias and areas where people are actively going to, as long as you get the permission from the owners and managers and things of that nature. One of the things you can do is you can wear a pin that says "Ask me about Medicare" on your appointments. I know that's very popular around the country. Agents are going out on appointments. They wear these pins. It says "Ask me about Medicare." You're sitting down with the prospect. The prospect's looking at you. The prospect's looking at the pin. They're looking at you. They're looking at the pin. It's almost, a given. They're going to ask, well, I'd like to ask you about Medicare. So in essence, they're provoking you. You're not provoking them. Bottom line, you must have established permission to contact in order to conduct an appointment for a Medicare Part C or Part D product. Kind of goes back to what I said earlier, no unsolicited contact. So as long as there's a business relationship, as long as you follow the rules, you can all day long have conversations about Medicare Part C and Part D plans as long as you get in permission in writing, the person's intent to have a conversation with you and what products that they want to talk about. And as I said before, the goal is to establish a clear line in the sand between a conversation regarding health products and a conversation regarding non-health related products. Senior sensitivity must always be applied. So let's talk about this scope of an appointment form. What is it? Okay, for one, back in the old days, 5 or 6 or 7 years ago, you had to use the specific insurance company's scope of an appointment form. Nowadays, all the insurance companies take all of the other insurance companies' scope of an appointment forms. Okay, they all recognize that before the consumer wants to have a conversation about a Part C or Part D plan, neither you nor the consumer have any idea what plan is going to be the topic of discussion. And unless you're a captive agent, you have multiple plans to offer. So all of the major carriers will accept a scope of an appointment form from another carrier, or a generic scope of an appointment form. One of the things that you as the agent must do is you must retain it in your files for no less than 10 years. You can obtain a scope of an appointment by electronic signature, fax, email, scan, snail mail, text message, because now Aetna allows that, and also WellCare now allows that, in person or via a telephone recording equipment. Additionally, the carriers have their own methods to obtain the scope of an appointment form as well. However, not all carriers accept all forms of scope of an appointment. Now, what do I mean by that? For example, United Healthcare will not accept a United Healthcare will not accept an electronic signature. And SilverScript will not accept a voice recording. Okay, so you got to be a little bit on the carrier specific side. And then also when I use the term major or large carriers, if you're selling smaller carriers, more rural, local HMOs, you want to find out what their rule is as well. They may have their own specific rules, but this whole thing is kind of really geared towards the major players that work in multiple states and so forth. It must be documented prior to any discussion of Part C or Part D plan. Good practice is to have the beneficiary initial all the boxes just in case they ask about a product not originally agreed to discuss. Otherwise, if the beneficiary brings up a product not agreed to, you must get a new scope of appointment form. So what does that mean? That means that you got a scope of an appointment form and they want to talk about prescription drug plans. You're sitting down with them, they look in the eye and say, tell me about the HMOs. Well, you can, but you just have to get a whole new form signed. Now, imagine if you weren't sitting down with the person, if the two of you were remote, you were in one location, they were in another. It's not as easy to get a scope of an appointment form remotely as it is in person. So good practices is when you get the scope of an appointment form, just ask the person to initial all the boxes, and I'll show you what it looks like in just a second. That way, if anything comes up in conversation, you're fully covered, they're fully covered, and you don't have to get another form. It makes life a lot easier. It must be submitted to the carrier at the time of application or shortly thereafter. Okay, I must put an asterisk here as well. If you make a specific plan presentation, for example, you presented to them Humana, and they didn't buy the Humana plan, you still have to send that scope of an appointment form to Humana. Okay. Aside from unsolicited contact, this is the #1 channel that CMS and the carriers will seek out to ensure agents are marketing compliantly. If you ever get a client complaint, and a client complaint is not where the client calls up and says, that darn agent, how dare he do that to me? I can't believe it. I want to file a complaint. That's not the kind of complaints that generally we get in the field. The client complaints we get in the field is the client didn't realize that they had a deductible, so to say, and they go in to fill a medication, and it's not a tier 1 or tier 2. The doctor just prescribed it. The pharmacist says that'll be $310. They say, well, the agent never told me that. And they call up the insurance company saying, why is this medication $310? The insurance company says, well, you have a deductible. And the insurance company says, well, the agent didn't tell me that. The agent told me that my medications were for free. Boom, that's a complaint. Even though they didn't complain about you, it's a complaint. So what happens there is immediately the insurance company is going to send you a letter. You have 5 days to respond. And in that letter, the very first question they ask, first and foremost question is please provide permission to contact. In other words, how did you and that client ever meet? Second question they ask is where is the scope of an appointment form? Please include it with this letter. First two questions they ask. And that's when this stuff comes up. Always document the scope of an appointment, even if the beneficiary is not sure what products they want to discuss prior to any Medicare conversation that could involve Part C and Part D plans. Clients don't know. Clients don't know there's a difference between a supplement and a Part C. Clients have no idea. Clients don't know that prescription drug is sometimes offered separately. They just don't know. So you always want to document it. Document, document, document. There are multiple means to get it. It's not hard. We use mostly electronic signature. Everyone will have access. Everyone that works with our agency will be given a username and a login to obtain electronic signature for the scope of an appointment form. It's non-branded. It's non-specific. Once it comes back, you sign your own name to it, and it can be submitted and accepted by all the carriers. It works very, very, very well. It's very easy. If the person has only a cell phone, as long as they have an email address, the scope of an appointment shows up on their cell phone. They can use their finger to draw their signature, and then they hit the submit button, and then it's done. We make things very, very easy, very, very simple. Okay. And finally, it can be obtained at the time of an appointment. However, you must explain why on the form. So in other words, person calls you up on the phone and says, I want to talk about Part C plans. And you say, great, we got to get the scope of an appointment form signed. They say, great, I want to talk about it right now. And you can, as long as you document why. And in a case like that, you would document, client called me and asked to talk about Part C plans. And that's how you would do it. Okay. Moving on, this is what a generic scope of an appointment form looks like. This one has been approved by CMS. It is available out there. I will make sure everybody has access to this. And if you take a look over here, these are the 5 products that the person generally would agree to have a conversation about. These 2 here are the main ones that the scope of an appointment is centered around. These 3 here are not required to have an SOA, although it is recommended. These 2 here are required. Okay, so going back to what I said before, when you have a client that wants to have a conversation about Medicare Part C plans, you just basically just want to have them initial all the boxes. It covers all the basics. It allows you to talk about all the products. There's never going to be a confusion. You'll never have to get a second one. The beneficiary has to sign here. It has to be dated. If they have an authorized representative, they have to sign here. An authorized representative is not a power of attorney. It's somebody who has been given legal permission to make healthcare decisions on their behalf. And then over here, you got to complete this, you as the agent. So you got to complete your name. You got to complete your phone number. You got to put down the beneficiary name. The beneficiary's phone and address is optional. The initial method of contact. So in other words, how did you and the beneficiary contact each other? Was it through telephone? Did they approach you in a public setting? Did they call you up from a referral? Did they come to you from an educational event? What is the initial method of contact? For the most part, the obvious answer is going to be telephone most of the time. People and you contact each other because of the telephone. You have to sign here. And then over here, this is completed after the appointment is done. So the date of the appointment, And then what plans did you represent during the meeting? Did you talk about Part C, Part D, PDP? What did you talk? What was in that conversation? If these two dates are the same, signature date and date of appointment completed, you have to complete this little box here, and you just have to explain why the scope of an appointment was not documented prior to the meeting. Because during the course of conversation, the client said, hey, I want to talk about Part C's. You just have to document it. It's not saying you can't do it. They just want it documented. Okay? Part C and D's, must-dos and best practices. Okay, so here's a good kind of thing that you want to try to install in your practice on an ongoing basis. First and foremost, if you're marketing Part C plans, you must confirm each doctor is in or not in the plan's network. Okay, that's a very important thing that you must do. You also want to do this for PPO plans, preferred provider organizations. Even though a PPO enrollee can go see any doctor they want, whether or not the doctor's in or out of the network, it's always a good practice to confirm all the doctors in the network. The best practice when confirming the doctors are in a network, and we'll go through this. We do this a little bit more in detail on a different training, and that's how to analyze a Medicare Advantage plan. But a good practice to confirm the doctors in the network is to look up on a search engine the doctor's name, confirm the name and address with the Medicare person to make sure that you have the correct spelling and the correct doctor. Clients don't always know how to spell their doctor's last name. I couldn't tell you how to spell my doctor's last name. I can tell you what his last name is, but I couldn't tell you the correct spelling. Then use the doctor's zip code, not the Medicare's beneficiary's zip code. Why? Why would you want to use the doctor's zip code to look up the doctor in the physician finder and not the person who you're sitting there with trying to help? Because of the algorithms that are involved in the physician finders. Okay, when you put in a zip code, you also have to put in how many miles radius, 5 miles, 10 miles, 15 miles. And it's just basically going off of a basic map. If you put in the person's zip code, that doctor may be outside that 5-mile radius. It might be outside that 10-mile radius just based on algorithms. And that doctor may not come up in that physician finder, but yet they are a contracted doctor. So good practice is to always use the doctor's zip code when looking up the doctor in the physician finder. This will ensure that you're looking up the right doctor. Never take the word of the client for the spelling of the doctor's name or location. Always confirm it on the internet. At best or worst, call the doctor's office and confirm. Okay? Never take the word of what the client says, because many a times have I had agents call me up on the phone and say, Joe, I got a client and I can't find a plan that any of their doctors take. They have 3 doctors. I say, what are your first 2 that you're considering? They give me the names of the plans. I go into the physician finder. I find those 3 doctors in lickety-split time, in 3 seconds. All because they took the word of the client on how to spell the doctor. They did not use the doctor's zip code. You can give out bad information to a client, and it could impact their decision or what's in their best interest by not accurately and correctly looking up doctors. If the client sees a physician's assistant or a nurse practitioner, you have to ask who is the physician that they report to. Physician's assistants and nurse practitioners cannot serve as primary care physicians or PCPs on a health plan. Okay, they're merely, and I'm saying this in a polite way, they're merely the helper of the doctor. Even though they do have prescribing rights and they can diagnose condition, they still have to work under a physician. And the physician is the only person that can act as a PCP. If you go and look in the PA's name, you're not going to find them anywhere as able to serve as a PCP. What you also want to do is you want to screenshot or you want to print each proof of the network doctor, and you want to store it in the client's file. Okay, very important with that because what winds up happening is doctors' offices and health plans aren't always synchronized with each other. Okay, a lot of times they are, but they're not always synchronized. So what happens is, in a case like that, is you want to have the printout, so if there's ever a discrepancy down the road, you have a piece of paper that says otherwise. So if the client ever says, my doctor said that they don't take this plan, well, here we go. According to the contract that your doctor has with the health plan, they surely do. Another good practice is to provide these to the prospect and the client as well. A lot of times we include the physician finder proof when we send out the summary of benefits and everything else. That way the client feels comfortable that their doctor accepts the plan, because that's really one of the most important things that people always ask is my doctor going to take this? Be mindful towards the end of the calendar year. A lot of times a doctor may opt not to contract with a plan that they're networked with today. It's not common, but it does happen. So these are the kind of things you want to be cognizant of as we're getting towards the end of the year. Just because the physician finder says yes, the doctor takes it this year, it does not guarantee that the doctor will accept it next year. The health plans try to get the contracts done around this period of time for next year, but it doesn't necessarily mean that the doctor signed the contracts in a timely manner. You want to enter each prescription drug into Medicare.gov to confirm on the formulary. We go through this in good detail when we go through how to analyze prescription drug plans and how to analyze PDP plans, but these are just some good practices. You want to have the client spell the medication out, frequency and dosage, if you are doing telephone presentation. Obviously, if you're face-to-face, you can just ask the client to go get their prescription bottles, and then you can visibly see what the medication is. You got to be cognizant for them as well as for yourself to make sure you have all the letters, such as HCTZ or MCGS. If it's a capsule or a tablet, it makes a difference. Metformin comes in two ways. Metformin comes in as extended release, and metformin comes in as regular. You put metformin in as extended release, no health plan is going to have it as coverage. It's going to look like it costs $3,000 a year, and you're going to be sitting there with the client saying, shoot, I can't help you, all because you made a mistake. So you got to be crystal clear. If you put metformin in as metformin, which is the way that it's commonly prescribed, in 90% of the health plans, that drug will come up as free because it's a tier 1. So kind of little things you want to keep in the back of your mind. You want all the letters of the medication. You want to be exact. Like I said, one small mistake in the medication can throw off the entire analysis. I mean, the whole thing will be thrown off if you put the medication in incorrectly. Also, you want to store the prescription drug list ID and password date from Medicare.gov in the client's file for future use. We go through this in detail when you go through the Part C and Part D modules. Real quick, what happens is when you put in the customer's Part C plan, you're able to record the number and the date, and you could always go back, and the medications will always be in there. You never have to enter it twice. You must go over the health plan's deductible, cost sharing, coverage gap, the donut hole, catastrophic coverage, all 4 phases. You have to look at RX, or you should look at RX coverage as overall annual cost, but you also want to break it down for them month by month as to what they could expect. And you must go over the summary of benefits with the client for the plan you are recommending in detail. Be mindful of using preferred pharmacies. A lot of times you'll have a client say, well, I get my medication from Kroger's. And you go in and you put in the medication, and Kroger's is not a preferred pharmacy for the plans you represent. That can throw off the recommendation. So you always want to have the conversation ahead of time, Mr. or Mrs. Client. In the event that we can find your medications at a lower cost, and that may mean changing pharmacies, would you be open to that? I have yet to come across somebody that has told me no. Everybody will say yes to that question. So be mindful of using preferred pharmacies. Changing pharmacies is not difficult at all. It's a phone call. That's all it is today. It's all it is a phone call. You call the new pharmacy, and the new pharmacy goes over to the old pharmacy and transfers everything over. It's a phone call. Ensure the client has a thorough understanding of the plan's limitations, costs, and pitfalls. If it's an HMO, you need to stress only plan doctors and referrals, unless it's an open access HMO. If the plan is a PPO, you need to stress the out-of-network doctor may not agree to bill the plan directly. Now, what does that mean? So in a PPO plan, you can see any doctor you want.
That's part of the deal. You pay a little bit higher for it, but that's part of the deal. But does that mean that the doctor is going to bill the health plan for you? No, absolutely not. As a courtesy, most will, but it doesn't mean that when you go see that out-of-network doctor, that an out-of-network doctor is going to collect your copay of what your out-of-network benefit is, and then go and bill the health plan that he or she doesn't contract with to be paid for reimbursement. They may require you to pay the whole fee, and then you have to go and seek reimbursement. You don't want to get into that too deep with the customer for the PPO plan, but you do want to casually mention that if they do use out-of-network doctors, they may be responsible for the charges, and they may have to solicit the health plan for reimbursement. And then the other thing, you want to drill into these people's heads as best as you can. If the plan or the prescription drug plan, health plan, has an RX deductible or health deductible, you must ensure that they are 100% aware of it. Mention it 50 times. Have them repeat it back to you. Go over it a million different times. I would say that's probably the number one reason clients complain to the health plan or the drug plan is the fact that they were not told, or they didn't remember. They probably were told, or they didn't remember they had a drug deductible. And it's just like I said to you before. They may be on tier 1 and tier 2 generics. The health plan may offer it to them for free if they do mail order. They've been receiving their free medication for 2 years. They went to the doctor. The doctor says, we need to put you on medication. They go to the pharmacy to fill it up. It's a tier 4 name brand. The medication's $600. They have a $400 deductible. The pharmacy says that'll be $400. And the people flip out. That is the number one complaint. You have to drill it into their heads that even though their current medications are free, however, if they're ever prescribed something through the year, they will be responsible for the first X amount of dollars. You have to repeat it over and over and over again. Prevent all those things. What are the required materials prior to an application? For a Medicare supplement, you must send them the outline of coverage, choosing a Medigap policy, and a blank copy of the application that must be delivered in person or via email, regular mail, fax, or snail mail. The best part is while you're doing a application for Medicare supplement, all of the insurance companies allow you to send it out directly through their website at their expense. So most common method is just to email it. Even if you're sitting down with the client, you can just quickly email them the required documents. If they don't have an email address, you can just go onto the carrier's website as you're doing the application for Medicare supplement, and then just click, and then the carrier will send them out the required documents. Part C and Part D plans is a little bit more delicate. You must include the plan enrollment book, if applicable, from the carrier's website, the summary of benefits, including the multi-language insert, the star rating sheet, the privacy policy. All that must be delivered in person or emailed, fax, or mailed at your expense prior to the acceptance of the application. So the first one could be done at the time of the application or shortly thereafter. The second one must be done prior to the acceptance of the application. Sounds like a lot. It really isn't. If you go to the carrier's website, you put in the zip code, you can rip all of those documents off, put it in an email, send it out. You are compliant. Just have a record of that if anybody asks. What is suggested, not required, is written proof of each doctor in the network and a snapshot of the estimated prescription drug copays and cost sharing directly from the Medicare website. Medicare allows you to create a very user-friendly report with the click of a button, and it is recommended that it is sent to the client as well, so the client knows exactly what to expect when going into this. Overall bottom line, always do what's in the client's best interest, not yours. You do that 100% of the time, you will have 100% of success. Medicare Part C and D plans beginning of the first of the following month. What that means is do not rush. Take your time evaluating and be thorough. A Medicare sale oftentimes is not a one-call close. A Medicare sale is a consultative sale. It's based on analytics. It's based on relationship. It's based on understanding. When you're talking with somebody, today is September the 6th. If I have a conversation today with somebody about Medicare, Their Medicare plan that we're talking about is not going to begin until October 1, no matter what. So I got an entire month to do my job and to do my job correctly. So take your time. If you have a few weeks before the plan starts, there is no rush. You want to take your time, okay? Medicare supplement plans generally take 1 to 5 days to underwrite if you're doing replacements. Turning 65 is different. Be sure to carefully select the changeover date, which gives you and the client enough time to get the new policy and cancel the old policy. Most pay their premiums on the first of the month, so target the following month if the upcoming first is less than a week away. So my rule of thumb is I always look and see where I am in the month, and if I'm on the first half of the month, I know I can make the change in this example for October 1. I know if I'm in the second half of the month, more than likely I'm going to make the change for November 1 for a Medicare supplement. You want to get it right the first time. You don't want to have to go back and redo. This is not the type of product that you want to cancel and redo with a different carrier. If you do a Medicare Advantage plan and the client disenrolls within the first 3 months, you get what's called a rapid disenrollment. Rapid disenrollments are a strike against you. They're not good. It's not like life insurance where you sell a policy with carrier A and then 2 months later you realize carrier B was a better fit. You cancel A and replace it with B. It's a little bit different when it comes to health. You don't want to do things like that. You want to get it right the first time. And then finally, when in doubt, stop. Just stop what you're doing, phone a friend, ask a question. It's not an urgent matter. It's not like it's the night before with 2 minutes to go and the person has to make a plan selection. That's not the business that we run. Things that you want to consider, just kind of an overview and a cap of the more important stuff, is that you always want to explain the plan deductibles, and you always want to make sure that beyond a shred of doubt that they understand if they have one, that they could be at risk to pay it. Just as I said before, if you notice, I'm saying a lot of the same things over and over again, all because this is what comes up in complaints. You want to use examples such as Mrs. Prospect, your current medications, or Tier 1 generics, and not subject to deductible. They will cost you zero copay in your plan. However, if the doctor prescribes you an expensive name brand medication in the middle of the year, you may have to pay the first $410 of that medication. You do understand this, correct? You just want to make sure when you walk away that there is no doubt in their mind that if these scenarios come up, this is what the outcome would be. In a PPO plan, even though a member can see out-of-network doctors at a higher cost share, that network doctor, the office's first response to the member may be, well, we don't take this. The doctor's office can create a controversy with your plan recommendation. Be mindful. So you confirm in the network, the client has 4 doctors. You confirm 3 in the network, 1 not in the network. You come to find out the client sees that doctor once a year. No big deal. You tell the client you can still see that doctor. Instead of paying $50 copay, you're now going to pay $75 as an out-of-network benefit. You've done your job. Client goes, sets the appointment with the doctor, goes into the doctor's office. Doctor says, hey, have you changed your health insurance? Client says, as a matter of fact, I did. Here's my new card. The girls at the office look at it, they flip it over, they turn it on its side, they give it back to the client, and they say, I'm sorry, we don't accept this. And guess who's getting a phone call from the doctor's office in the middle of the waiting room? Angry, upset, mad, agitated. You told me. You told me. They're not taking it. I can't get into my appointment. So you need to be mindful of this, that if they are on a PPO plan and a doctor of theirs or a doctor that they want to see is not on the network, you have to be mindful and let them know that this could be one of the obstacles that they overcome. So prior to going in for that visit, they want to make sure their health insurance is in order with that particular doctor's office. Very, very important. Okay, this is, again, I would say this is probably number 2 in terms of complaint. 1 is deductible, and number 2 is the doctor doesn't take it. Thirdly, in HMO plans, the member is required to get a referral to see a specialist, even if they already have an active relationship with said specialist. So what does that mean? That means that you picked up a new client, The client's been seeing a cardiologist for 10 years. They go in once every 6 months. The appointment is automatically set for them. It is what it is. It's their life. They know it. And now all of a sudden you put them in an HMO plan and they cannot freely go into that cardiologist's office as they once used to. They have to get the referral through their primary care physician. They need to be made aware of this. Now, it sounds worse than what it is. They can go in the beginning of the year and they can set up all of their ongoing maintenance referrals in one shot. It's all done electronically. It used to be they faxed the referral over to the specialist, so now it's all done electronically. But with HMO plans, they have to get a referral, even if they have a relationship with the specialist. Only in times of an emergency, and dermatologists, and I think podiatrists. Don't hold me to the podiatrist. I'd have to look that up. Those are the three situations where they would not require a referral. And then finally, when in doubt, if you're not sure about someone, if the conversation's not going the way you're thinking it's going, if you don't have a good feeling that they're not understanding, if it's just too much for them to kind of process and divulge, when in doubt, ask to have a family member or a trusted friend of the prospect be part of the conversation. Family members are always good. We're at the end of the module, and one of the things I'd like you all to do, if you've sat through this, is if you can just send an email to nationcareservices@gmail.com, and in the subject line, type your first and your last name, and also include compliance basics completed. We as uplines, we're given certain responsibilities, and one of them is always going to be compliance training. So this is kind of our way to document that you've sat through the training. And then what we'll do is we'll just maintain a record of completion in your file. At this point, I'm going to turn the recording off, and I'm going to field any questions if you folks have any questions. So hold on.